Please join me in welcoming Dr. Megan Sandel.
Good morning. Good morning. When they told me I had to follow David Erickson, I almost said I wouldn't come because he is so good and he is so hard to follow. I've already tweeted once this morning the brilliance that he's already said. So it's interesting. I want to call attention to my title because I changed it after they printed the program. And so I want to call attention to the fact that I now talk about it as home as a vaccine, not just housing as a vaccine. And I do that very intentionally because I think that one of the things that is really important is that when we say the word housing, what we've learned from the research is people think of 4 walls and a roof. They think of it as a commodity. They think of it as, sometimes they automatically put the word affordable in front of it, and they will think of it as other. Whereas when I say the word home, that is something that everyone in this room can connect to. It's something that everyone has a vision and an emotional attachment to. And so that I just want to encourage us more and more. We are in the home business, right? Like all of us, social services, transportation, community development, health, we are in the home business because it really is home that is the vaccine that we are talking about. I also want to kind of throw around 2 terms called population health and health equity. And the reason, and I'll go into them in more detail, I feel like they're not always well understood. And again, as Mandy alluded to, by not having, I think, a common set of language, we actually don't move forward because we mean different things when we say them. So I'm going to give you the Megan Sandel version of what population health and health equity and see it. And then I am going to try and actually not to talk the whole time. I'm hoping that we'll have this as more of a conversation. I'm going to try and talk for only about 30 or 40 minutes and then have about 20 or 30 minutes for conversation. I requested that they put index cards on the table so that as I talk, if you're thinking about a question, write it down, hold it up. Mandy and other volunteers will do it, and then they'll bring it forward to me so that we can kind of open this up more. All right, so the kind of roadmap of what I'm going to do over the 30 or 40 minutes, I'm going to talk about the different dimensions of which homes affects health. I sometimes will talk about it as the 4 walls on some level, right? Quality, stability, affordability, and location. As this is an area where there's been a lot of research, a lot of understanding. We often think about only one dimension at a time to our detriment, so I want to kind of make sure we talk about all 4. I'll talk a little bit about how this kind of concept of home as a vaccine has really resonated deeper and deeper with me. Talk a little bit about why do we invest in vaccines? Why do we think of them as good investments? How a home can act like a vaccine. I really want to thank Children's Optimal Health for giving me some maps of Austin. So I'll be able to flash up some of the great data that they've compiled to kind of deepen the conversation around not only thinking about ways in which we typically think about location around economic segregation or around racial or ethnic segregation, but then bring in the concepts of health and bring in the concepts of time as neighborhoods change and what do we think about that. I then want to kind of talk a little bit about homes and population health, bring you some hot off the press data that we are just submitting for publication from Children's Health Watch around how kind of homes can fit into a population health pyramid. And then lastly, I always pretty much end my slide around equality doesn't mean equity. And so trying to kind of talk about what that means. All right, so let's get rolling. So the evidence on home quality and its impact on health is actually centuries old, right? We understand it first to be tied a lot to accidents. People may not realize, but about half of the accidents in the United States are tied to motor vehicles, and the other half are tied to where you live, right? You know, whether it be about falls, whether it be about drownings or other types of things, these are all things that are tied typically to where you live. And so things like, wiring or exposed or repairs or things like that, accidents are actually an incredibly part of home quality. I actually first got into thinking about homes in thinking about asthma, right? I admitted a child to the ICU as a young pediatric intern 20 years ago. I was in diapers at the time, so it was a really easy thing to, no, I'm teasing, but it's, I'm aging myself, but it's, we ended up admitting a child to the ICU, and we were tearing our hair out trying to get this kid to to breathe. And I ended up asking the fateful question to the family, what had changed, right? And the family talked about getting a cat. And I was kind of mystified. According to her chart, she had actually been allergic to cats. And so I said, why did you get the cat? Any guesses why they got the cat? Mice. They had found a mouse in the kid's bed. So they couldn't get the landlord to make a change. They made a choice that probably resulted in their kid being hospitalized in the ICU. And so it was this eureka moment to me where it was like, oh my God, the prescription I wanted to write was for a healthy home, right? No amount of medicine I was going to give was going to make that better. And so the evidence around developing and worsening asthma around town housing quality is again, just decades old in terms of thinking about pests, cockroaches and mice, thinking about mold and chronic dampness, tobacco smoke. 86% of kids in the United States are exposed to tobacco smoke the ones that are exposed to tobacco smoke are exposed in their home, right? And so when we think about this, it becomes really important. And then I think, especially in the last year or so, we've rediscovered lead, right? We've kind of thought about lead as an exposure, both in paint and in water. And that's tied to, obviously, lifelong effects sometimes around developmental delays and attention deficit. What isn't always tied is we tie housing quality with physical health, right? But we don't always tie it to mental health. And for those that want to dive deeper into some of this evidence base, I want to recommend the MacArthur How Housing Matters series. The MacArthur Foundation did a long group of investments in understanding how housing matters. This is a brief of a peer-reviewed journal article by Rebecca Levine-Coley at Boston College, where what she found that actually the poor housing quality was the strongest predictor of emotional and behavioral problems in low-income children. And that really much of that association with poor housing quality was actually tied through parental stress and tied to parental behaviors and mental health. And so when we think about home, I think we often, I'm a pediatrician, I'll talk about it as a kid issue, but it's a two-generation issue, right? It's as much about parents as it is about kids. It's as much about physical health as it is about mental health. Stability is the next dimension. As we think about kind of quality, then we also want to think about stability. And what I will often say is that homelessness is the part of the iceberg you can see, right? It's above the surface, but there's a lot of iceberg below the surface. And so as we think about solutions to end homelessness, we have to acknowledge that iceberg, right? We can't just lop off the iceberg and say, great, we're doing great, and then not necessarily think more holistically. And so that there's often a hidden homeless in our population that is tied to things like housing insecurity, things like moving frequently, moving 2 or more times in a year, sometimes even being overcrowded or doubled up in these unstable kind of housing situations. And ultimately, we're talking about affordability. We actually found in our research that a simple indicator of being behind on rent, so answering yes to the question, have you been behind on your rent or mortgage, is incredibly predictive of other household hardships. 4-fold rates of household level food insecurity, 3-fold rates of reporting that you're cutting back on the size of your kids' meals, child food insecurity, almost 4-fold rates of energy insecurity, reporting that you may have received a shut-off notice, you may be using a stove to heat your home, and then a lot of foregone healthcare, foregoing healthcare related to costs, child foregoing healthcare, making healthcare trade-offs. And so oftentimes the affordability ends up being a really kind of a cascade of effects that can be really important. Finally, as we think about kind of the dimensions, we talked about quality, we talked about stability, we talked about affordability. I think we have to grapple with the fact that we haven't moved the dial enough on location. So as we think about kind of how tight poverty and zip code remain linked, this is a map of New York City where the black dots are illustrative of places where there was concentrated poverty, more than 30% of people living below the federal poverty limit 30 years ago. And then the people that are now the hot red spots are the places that are continuing to be having that same level of concentrated poverty. And what you can see is there's a lot of overlap between the red and the black dots, right? And so as we think about this, it is, I think, ultimately around how we understand zip code, how we understand concentrated poverty, how we think about those tools. And so that what I have come to realize is I can give you a stable, decent, affordable home that has all of those three dimensions. But if you're in a neighborhood that is with concentrated poverty, that may undermine those three other dimensions, right? And so that's the research of Raj Chetty and others in thinking about ways in which we need to think about it. I will say that to me, this is a twofold. Some people will look at this map and say we need to move people out of those neighborhoods. And other people will say we need to make the neighborhoods better. To me, it is not an or, it is an and, right? And so we have to be really thoughtful about that. I just want to tie in because I totally agree with David that ultimately health may be as much about education as it is around actual kind of physical health or mental health. And so one of the things that I think is important is this tie with housing and education. I was asked to write a blog. Don't ask me why they asked me to do this. The Economist said, will you write a blog about housing and education? And I was like, sure. And I told them the secret to education is actually affordable housing. And the reason is that when you look at many urban school districts, it's not unusual to have over 50% of the kids chronically absent. I'll show you the map of Austin actually in a minute. And there's also this concept of the churn, right? Where you basically start the school year in one classroom, you finish the school year in another. It's not unusual for sometimes to have 100% churn rate. In Tacoma, Washington, they actually had a classroom of 20 kids. They had 54 kids rotate through that classroom of 20 in a school year. 179% churn rate. And so it prompted the Tacoma Housing Authority head to say, could we use a housing dollar not only to create more stability for the family, but actually to create more stability for the school, right? To not only improve health outcomes and housing outcomes, but to actually improve educational outcomes. I think that the other thing is that as we are in a very tight testing market in terms of as we think about it, this is from the National Housing Conference, should I stay or should I go? And kids who move 3 times between the grades of first grade and 6th grade actually score on average about 20 points lower on their reading scores. And so what I often say is we're often universal in how we blame teachers for lack of school performance or other things, but I don't know how you teach kids if they don't show up or they don't stay long enough. I understand that unified curriculum is one solution to these things, but to an extent, this is where we as a community come together and say, it's about not only my student, but the student next to my student that become my child, that become really important as we think about it. So I'm going to step back and do a little bit of kind of public health 101. And what that is just talking a little bit about vaccines. Why do we vaccinate? Why do we think that vaccination is important? It first and foremost talks about personal protection, right? It's about my immune system. How am I going to prime my immune system for how I will be able to fight off an infection when I'm exposed to it? But it also is about this concept of what's called herd immunity, right? It's not just about the individual protection. It's about this concept of if we vaccinate enough people in the community itself, we actually will even protect those that don't get vaccinated, that there's kind of a tipping point that you see. What you can see in kind of this somewhat busy slide is the idea that if you don't have that many people that are actually vaccinated, the blues, right? And you just have a couple of reds, what happens is that if you're exposed to the virus, a lot of people get sick, right? So that's the people who get infected. What you see is that as you build a little bit of vaccinations, the greens, right? What you see is that you protect a little bit, but you still see a lot of infection as it comes through the red. But what you can see is that if you have enough people vaccinated, even when the infection comes through, those that aren't necessarily vaccinated are still protected on some level, right? So it gives you this sense of a communal type of sense, that it's not just about individuals, it's about a benefit to your community itself. What we can see is that it's not only a community benefit, but an economic benefit. And we've seen examples where when your herd immunity breaks down, you actually can have outbreaks, things like measles and other things that happen in California. We actually looked at this concept of how home could act like a vaccine in our research at Children's Health Watch, because we wanted to try and look at how does it necessarily build immunity against another threat. Can we think about ways in which this can benefit kind of both individuals and society? I just want to highlight this paper. This paper is actually from over 10 years ago. We published it in 2005, where we looked at those that were receiving subsidized housing versus those that were food insecure in food insecure families. And what we saw was that the kids in food insecure families, if they had a housing subsidy, were twofold less likely to be underweight. So they're in food insecure families, they have a threat to their likelihood that their kid is growing, yet the housing subsidy is protecting against that threat. And when we compared those against kids that were food insecure, eligible for the housing subsidy, not getting it, those kids were twofold more likely to be underweight. So when we think about it, it is kind of this vaccine, this home is a vaccine to make things healthier. I want to just talk a little bit about the economic benefit. One of the things that's interesting is that they looked at the cost effectiveness of routine varicella, that's our fancy word for chickenpox, vaccination. And what was interesting is that it was not that we vaccinate kids in order to save money on the healthcare system. It actually doesn't save money. We spend $2 for every chickenpox case that we actually prevent. But when you take in the societal benefits, when you take in the work loss, right? We see that for every dollar you spend on it, you save $5 to society. And so that we vaccinate kids against chickenpox not to save the healthcare system, but to keep their parents working. And so that as we think about that, I think oftentimes we only think about the economic benefits of home in one sector. We only think about health. We only think about education. We only think about child protective services. We only think about jobs. But we don't bring it all together in terms of how we think about it, because that is the societal benefit cost. That is where we start to think about the marketplace moving forward. I'm really excited to share some of these maps. Again, want to thank Children's Optimal Health for putting it together. What's interesting is that as we think about kind of the layering of the maps, as kind of David alluded to, what you can see is what's called hot spotting maps. And so the redder the area that you see, the more likely you're seeing a higher concentration of things. And so this is where are the hot spots of people that are not economically disadvantaged, not taking advantage, or not being part of the free or school lunch program. And as you can see, we're seeing the hot spot in the lower area right here on the two sides. I'll try and not ignore the people on this side of the room. And then what's interesting is that you see a very different pattern as we layer on where are the more economically disadvantaged, people who are taking advantage of the free and reduced lunch rate, which is about 60% of the kids in the Austin School District. And so again, you see a very different map. You see up here in this neighborhoods, you're seeing higher concentrations and other things. And again, up here. What's interesting is as we kind of, in your mind, kind of keep that in mind, the kind of where the less economically disadvantaged kids are, where the more economically disadvantaged kids are, we start to layer on what does race and ethnicity look like. So we see white kids are more likely to be in these areas in the lower school districts. About 26% of the kids in Austin School District classify themselves as white. We see about 60% are Latino and Hispanic, and we see a little bit more of a crescent, right, around things, not necessarily just isolated in the upper, but also down here in the lower. We see about 8% are African American, less concentrations as we can see up here. And then the Asian American population, about 4% of students, big scatter, right? In terms of not necessarily a concentrated hotspot in any given areas, some smaller areas as we kind of layer on. So we've layered on kind of income, right? Economics. We've layered on race and ethnicity. And so now we can kind of think about health and how health kind of brings into it. And so in this, we see that there's the first one is education. Where is the density in kids that are missing more than 10% of the school year, right? That's the chronic absenteeism standard. And what you see is, again, this kind of ring around kind of where things look in this area. And then as we layer on the students with asthma, what we see is the hot spotting here is where you actually have kind of bad enough asthma potentially to have a care plan actually registered at the school. You have a plan for your asthma to try and see it. And again, you see a little bit of a scatter. It's somewhat a little bit higher up here, but you see some lower here. And I think that's an interesting map. This is as much about kind of severity of asthma as it is about asthma quality, right? Your doctor should be giving you an asthma care plan. And so it's interesting how those, again, these patterns are both spatially kind of related, but also people related. And then finally, I think it's really interesting to look at these maps over time. And so this is actually looking at the obesity-related kind of people who have elevations in their body mass index. And what you can see on the left-hand side is the years 2008 to 2009. And then on the right-hand side, the 2014 to 2015. And what you can see is in specific neighborhoods up there, you can see that there are pretty significant changes from one year to the next. And so I'm going to kind of walk through the circles here. Those two neighborhoods kind of at the top are changing, and then the bottom two neighborhoods are theoretically improving, right? So you see kind of the top two get more red, the bottom two get less red. And so it behooves a little bit of a question of what does that mean, right? Is it that you're shifting zip code, you're actually making things better, right? Or is it that this is just marking that people are moving, right? Where are people being displaced from? Where are people moving to other areas? And I think that that is where maps are incredibly important in terms of both, I think, answering some questions about where you need to focus. We'll talk about that in a minute around kind of equity. But I think it also behooves us to always ask questions about what does it mean, and how do we change the maps, and how do we kind of think about them, and who are we serving? So I want to kind of shift gears and talk a little bit about population health. I want to acknowledge that I have a love-hate relationship with the term population health. I love it in the sense that it is my sector, the healthcare sector's way of finally engaging in the social determinants of health. It's my sector's way of finally talking about beyond the individual patient in front of them and thinking more holistically about patterns. I hate the term population health because it basically superimposes onto a term that's been around for centuries called public health, right? And that it doesn't always, I think, acknowledge, and as in the healthcare field, if we haven't invented it, it doesn't really mean that it matters. And so I tend to kind of be an optimistic person, so I'm going to take the glasses half full approach and embrace population health as a way to really talk about it. But I think it's really important that as we talk about it, we don't continue to perpetuate really what David alluded to, that health care is the only route to health, right? So we have to start talking about our social determinants of health in population health terms. And we have to be able to integrate those into it. And so when oftentimes when we in the healthcare field talk about population health, we talk about the population health pyramid. And the reason for that is that we think it's really important to basically map people towards risk, right? And so as you look to kind of the right-hand side, how do we think about it in healthcare alone terms? It basically is tied to risk for utilization. Because the reality is that the top 5% of people use up 50% of the healthcare dollars, right? So 5% of people use 50%. I can give you a lot of 2% use, over 25%, 1% use, at least 15%. Like you can choose whatever kind of metric you want, but the reality is that you have disproportionate cost, right? And so as we think about that, those 5% are what people care about. We have a lot of different terms for them. Super utilizers is sometimes the term people use, frequent flyers. But the reality is that we're talking about the top of the pyramid, right? And the fact that they use a lot of healthcare. There also is this term called rising risk. So they're the people that are high risk for a lot of utilization. And then there's also this term rising risk because those are the people that if you catch them early enough, you can prevent them from becoming high risk, right? So you're trying to think about prevention and things like that. As we sort of think about kind of in public health terms, the tertiary, secondary, and primary prevention, the top of the pyramid is the tertiary prevention. You're really sick, we're trying to get you healthier. The middle group, the rising risk, is kind of the secondary prevention. If we catch you early, we can actually bend the cost curve of how we think about it. And then the low-risk patients are the ones that you want to try and keep healthy, you want to try and do things for. And so what's important is that this is how more and more we in the healthcare field are defining our populations. What's the population health pyramid? Where do they fit? What are the metrics of which we do this? I think it's important to think about a home-based risk pyramid, right? Where the top of the pyramid may be people that are homeless. But again, as I talked about in kind of the home stability iceberg, right? The people who are right below the surface, the rising risk group, the people that are a paycheck away from being on the street, the people that are moving frequently, not stable or other things, those are the rising risk group that become really important. What's important, and I'm gonna share some data in a minute from our Children's Health Watch network, is that people have tended to think of it as an either or instead of an and. And so I'm going to present some data to try and kind of highlight the fact that when we think about health and risks and things like that, the rising risk group in the home pyramid may be as high of risk as the homeless group. So for those that aren't familiar, Children's Health Watch is a nonpartisan network of pediatricians and public health researchers. And our goal is really to try and improve the health and development of young children and their families by really focusing on the public policies that can alleviate economic hardships. We tend to focus these days in 4 main areas. We focus on hunger or food insecurity, unstable housing or housing insecurity, keeping the heat or the lights on, which is a form of energy insecurity, and then adverse healthcare trade-offs. And we look at the interplay of those and trying to think about how things work. We collect data in emergency departments and primary care clinics in 5 cities right now. So Boston, Baltimore, Philadelphia, Little Rock, and Minneapolis. And in a survey, we survey the household, and we really focus on young children. So we interview only families that have at least 1 kid, 0 to 4. And we focus on that population because it is an invisible group, and it's a really critical window of brain development. We talk a lot about kind of preschool and showing up ready to learn, and we know that public policies often play out on the bodies of these young children. These kids are the canaries in the coal mine in terms of how public policies will come out. And so this has literally been submitted to pediatrics. We're going to cross our fingers. You're going to see it in a peer-reviewed. You guys get to see it first. But this is really where we're thinking about the health risks associated with unstable housing. And so as we look on one side, we see in our data set about 9% of people are homeless. And that means either living in a shelter or essentially being unstably housed with family members. We see about 6% of our population is actually what's called multiple moves. So they've moved at least 2 times in a year. We see about 25% of our sample answers that they've been behind on rent. So that's about 1 out of 3 of our families answers yes to 1 of those 3 questions. And what's interesting of note is we looked at this data over about a 5 or 6 year time period, about 22,000 families we had interviewed in the 5 cities. About 7,600 of them answered to at least 1 of them, but 86% of them only answered to 1 of them, right? There is not a lot of overlap between these 3 categories: homelessness, moving a lot, or moving at least twice in a year, and behind on rent. They are distinct forms of housing instability. But what's interesting is that when you look at those 3 together, what do you see? You actually see a range of 20 to 24% increased risk of child hospitalizations in that group. And what's important is I'm still working on the layout of this pyramid, it's not that homelessness is 20 to 24%, it's any one of these 3 predicts to 20 to 24%. So it's important to understand that behind on rent may be just as bad as being homeless in terms of predicting to child hospitalizations, right? That we see in this group of these 3 housing instability factors, a 26 to 31% increased risk of developmental risk. That's having 2 concerns on a developmental screening tool, and that is very predictive of whether you're going to show up to kindergarten ready to learn. 174 to 260% increased rates of maternal depression, right? So I often, as a pediatrician, will only focus on the kid outcomes, but I'll tell you the adult outcomes are worse, right? And then child fair or poor health and maternal fair or poor health, those are extremely predictive of, again, healthcare costs. increased rates of ambulatory care usage, and less likely to potentially be able to do well in school, do well in the job workforce. So as we think about this, it is increased risks with increased housing instability. And so that this is where we have to get a lot more clear when we're thinking about our population maps, we're thinking about our population risks. How do you make your own population health pyramid? And so as we think about it, I'm going to share with you our 3 assessment questions. This is how we classified people into this population health pyramid. And so we started with, since the current month of last year, was there a time you were not able to pay your rent or mortgage? And if you answer yes, then you're behind on your rent or mortgage. We asked, how many places have you lived? And this is important because oftentimes if you ask someone if they're homeless, they will say no to that question. But if you ask how many places have you lived and they say 5, that means that they have been moving multiple. So if you answer 3 or more, how many places have you lived? That implies you've moved twice, and that is unstable, right? And then ultimately, was there any time you were homeless or living in a shelter in the past year? And that's important because even having current homelessness is obviously important, but a history of homelessness is actually also very important, and I'll share some data around that. So these are really important, and I want to thank the Blue Cross Blue Shield Foundation of Massachusetts that supported this analysis, because what we've seen is we actually validated a 2-question tool around hunger called the Hunger Vital Sign, and we're excited to now talk about a housing stability vital sign that may be equally important in how you unpack Austin and the depth of the problem and how you're going to tackle it. I'm going to share a couple of research questions. I have about 5 minutes left, so I want people to start to write your questions, hold up the cards, bring them forward. We got some support from the MacArthur Foundation to look at a couple of different things. One was this concept of compounding stress, looking at the timing and duration of homelessness and how that affected child health outcomes. We had published previously, which is not necessarily a rocket science, honestly, piece of information, which was that if you were homeless during your pregnancy, you were more likely to have adverse child health outcomes in terms of birth weight and prematurity, right? Not rocket science, but important to document that exists. But what we then did is translated that forward, where we adjusted for those birth outcomes, prematurity and low birth weight, and then looked at what were the child health outcomes. And so what you can see is that the red bar is people that were homeless just in the prenatal period and then became housed subsequently, and you see a 40% persistent risk in child fare or poor health. You see a 28% persistent risk in developmental delays, a 23% persistent risk in being hospitalized. So that's the biology that David talked about, where homelessness is a toxic exposure that potentially changes the life course of kids, right? And that, as we see, just becoming homeless in the postnatal period has pretty similar effects. That's the yellow bar, where we can see that it's about 40% increased risk of fare or poor health, 38% risk of developmental delays, about 19% of child hospitalizations. And then the double whammy of prenatal and postnatal homelessness is off the charts. 100% increased risk of fare or poor health, 59% increased risk of developmental delay, child hospitalizations. This is all available. You can download this brief off of the web. But it's interesting. We looked not only at timing, right? Was it prenatal? Was it postnatal? Was it both? But we looked at duration. And duration was also really important. Infants are incredibly important in terms of their time period. If you are homeless for at least 6 months of your first 12 months of life, you have a 250% increased risk of fare or poor health, 118% increased risk of developmental delay, 46% risk of hospitalizations. And so what's interesting is that we have developed in the adult world a really robust way to categorize risk of people for permanent supportive housing. We have not done that on the family side. If you have an infant, you do not get extra points in terms of putting you at the top of the list, and yet this data suggests that that's exactly what we need to do. And then I'm just going to end with, we have talked about housing as a healthcare investment. I just want to talk about the fact that David's the banker talking about health, and I am now the pediatrician talking about financing. But it is this important thing as we try and think about what are the ways in which we can do cross-sector collaboration. And so what we did is tried to estimate the hospitalization costs attributable to homelessness in infants. And what we saw was that it's actually $238 million just looking at homeless families. It's about 18,000 hospitalizations across the country. Over half of them are with infants. And then we think that actually affordable housing can avoid at least half of them. And so as we think about those things, those become really important numbers, the business case. It's not just about collaboration, it's the business case that we need to start putting forward. And then my last slide, I'm going to talk a little bit about this concept of equality doesn't mean equity. This is a really nice figure that the Saskatoon Health Department in Canada allowed me to use, which is really talking about those differences in those terms. And so as we think about the different heighted people, right? You have a tall person, you have a medium heighted person, you have a shorter person. And we think about what it means to treat them all equally. You give them the same size box to stand on, right? So in that scenario where you treat everyone equally, only the tall person reaches the apple of opportunity on that tree, right? The medium height person gets a little bit closer. The short person is pretty far away, right? The difference on the other side of equity is that we acknowledge from where you start from. We acknowledge your different heightedness from the get-go. We say, okay, this person, this community needs one box to stand on to get to the apple of opportunity. The second person, the second community needs 2 boxes to stand on to get to that apple. And then the shorter person needs 3 boxes to stand on in order to get to that apple of opportunity. And so that inherent in equity is this really uncomfortable reality that to be able to have the same opportunity, the same fair shot, you have to treat people unequally. You have to give some people more. You have to acknowledge that they need more to get there. And so as we think about those maps of Austin, so as we think about ways in which we are going to change zip code, we have to acknowledge that equitable development may mean higher doses in certain places. That we have to think about that arc in terms of how we are able to change things over time. It's not a static process, as some people have pointed out to me. People can grow, and people can get stronger, and people can get bigger. But the reality is that we do need to be a lot more conscious of equity as we're thinking about investment. And I will argue that that first box at the bottom of everything is always going to be home. That if you don't do home well, nothing else you want to do is going to work. Your education program won't work as well, your jobs program, your criminal justice reform, it all, I think, starts at home. And so to me, that really is the foundation. I just want to echo David's remark. We've had a really wonderful time talking to all of the partners here in Austin, or many of the partners. I think you guys have the secret sauce that it's going to take in order to tackle this problem. I think this is a solvable problem, and I'm really excited to hear your questions and have a little bit more of a dialogue. Thank you. Now I'm making Mandy walk up here. There should be music, David, right? Like, dun, 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 dun. All right, awesome. Yeah. All right, so switching language from housing to home helps emphasize the emotional aspects of a stable home. Thank you for that. Can you talk about the mental health costs of housing instability and impact on creating stable homes? Yeah, thank you. It is a really interesting, I think, time just in the fact that actually when I speak to healthcare executives and other things and start talking about how to invest in housing and home, it's actually the behavioral health costs that are the most compelling to them, because that oftentimes is the one that is the most difficult. And so what I think is interesting to me is, thank you, is trying to think a little bit around, again, how to monetize that. There is very good research, particularly in chronic mental illness, behavioral health problems like bipolar disorder and schizophrenia, that home is actually a really good intervention that stabilizes it. The other piece of this is important to think about ways in which depression and economic stability are so tied together that if you're able to have a stable home, you're less likely to be depressed, you're more likely to work, and so being able to tie that. So I often don't want to just talk about it in terms of healthcare costs. I want to talk about it in terms of economic costs. And then I do think that as we think about this concept of stable home, I think that it's important both in terms of just acknowledging the ways in which we actually think about it's kind of hard to say. I am spending a lot of time thinking about language because I think that we are a divided nation, and I think that we need to have common language around these things. And I think that there are ways in which stability is a core value, fairness is a core value, and that I worry sometimes the word opportunity is more meaningless now, and so that I think we have to tie into words that we can all agree to. And so home is one, stable is home, fair is one, and that's where I think that we may be able to not only make a communication argument, but an economic argument that will be meaningful. So I did mention the term supportive housing, and I wanted to define supportive housing as a strategy. Thank you for that question. I think that there is something called permanent supportive housing, which typically is designed for a chronically homeless adult that has many either mental health disorders, sometimes substance use disorders. And what is interesting in that particular subgroup is that the economic argument for them is unbelievably good, right? Like, these are people that sometimes will cost $1 million a year. There's actually a great New Yorker article by Malcolm Gladwell that talks about $1 million MORI that cost not only from the healthcare system, but the criminal justice system, right? The sheriff's office and things like that. And so that I think that there's a great economic argument towards permanent supportive housing. What I encourage us to think about is not to just stop at permanent supportive housing, but to think about the next layer down, which is supportive housing, which is pairing housing services with health services, and being able to do housing and services together for that next step down. Maybe it's decentralized supportive housing where you have a case manager in a development taking care of a group of people, or you have a pairing of certain units set aside for certain high-risk families that may not be the top of the high-risk curve, but are at that rising risk curve, and you can think about ways to do that. I do think that is an area of real innovation that could come down. I was actually over at the Housing Authority yesterday. I think they are an amazing partner, that there could be a lot of real innovation. And this is where I encourage people not just to think about elders, but to think about families and to really innovate in the family space so that we can kind of avoid this one-size-fits-all. You're either getting permanent supportive housing or you're just getting housing. But we think about that targeted approach and being able to do it. What I say is that my most high-risk or rising risk families don't lack for case management. They have 4 case managers, but what they're asking that case manager to do is not in the wheelhouse of those case managers, right? The person from the Department of Children and Families, the person from the insurer, the person from their medical home, and the person from their Head Start program all don't know how to do housing search. And you're asking them to do housing search. And so they're not very effective. And so if there are ways in which we can start to consolidate and frankly think about this as a household issue, not an individual member issue, but that you're going to assign a single caseworker to an entire family that's linked across the sectors, that's where you start getting into the leverage that I think you need. Oh, I have so many questions. Okay. I got a nice comment, eye-opening speech. Thank you very much. All right. All right, so let's talk about the transformation of volume to value. So I do think that what tends to happen in the healthcare world is we were rewarded for essentially doing more and more care, right? So more times you came to the ER, great. We sent a bill off, we got paid, right? And now it is, so that's volume, right? Where just the more you do, the better you make money. We're now towards value in the fact that it may be as much about quality of care, hitting quality outcomes. And I want to just highlight 2 things with that concept. For those that may or may not be familiar with it, is value has a 2 side to it. We inherently go to the monetary value, right? That is, if you have a certain amount of money and you overspend, you lose value, whereas if you are able to keep people healthier for that amount of money and not spend as much, you pocket the profit, right? So that value, that is kind of essentially it's somewhat of a stick approach, right? This is your cap, and if you go below it, you're good, but if you don't, you're punished. You have to kind of pay out of pocket for that. The other part of value is quality, and I really encourage people. So in a lot of the work that I've done around asthma and community health workers going into the home, we do okay in terms of value, in terms of healthcare costs. We don't save a ton of money, but we actually put the money where it ought to be, which is actually in medication and doing better going to school and going to work, and less on the emergency room and the ER. But as more and more health plans will basically incentivize value, if you hit your quality metrics, you actually will get a bonus payment. I want you to think about that carrot and stick, that it's both. Home can be something that can help you meet your incentives as much as it helps you avoid the punishment of the value as it talks about moving forward. And so this is where, again, as we talk about common language, if you're in the housing world, you should know where your people who live in your housing go to healthcare, because then you'll know who to talk to. And in the health world, in the human services world, you should figure out whether people are housing unstable and where do they live, and who are their landlords, and how is that working? Because that's where we can start being able to mesh those two population health pyramids so they're not separate, but they're actually together. All right, so how might the Trump administration address the needs to, I really should edit these a little bit better. No, it's the dislocation of costs from one sector to another. This has been commonly referred to as the wrong pocket problem, where there has been more and more some discussion around whether or not there are ways in which you can actually blend funds together and be able to move things over. I do think that for the most part, the healthcare sector is first not a monolith, and also the dollars within the healthcare sector are interesting. I think I'm going to kind of separate them into three different dollars. So there is the dollar that is the payer-provider dollar, typically an insurance dollar, or how much money you get as a healthcare system. There is also a dollar called the community benefit dollar. A lot of hospital systems are not-for-profits. They don't pay taxes on their profits, and they're supposed to do some community benefit with those dollars. And then what people don't realize is healthcare has endowments that they invest to make money to help them achieve their mission. So there are ways in which all three of those, I think, can be incentivized to shift money from the healthcare sector to partner with the Housing and Community Development Center. I think first and foremost, services is something that's authorized to be paid for in most instances. And so doing health-related housing-based services is something that absolutely you can start having those conversations tomorrow with people about how those payer dollars can be used for that. And that's something that I think the waiver system, where a lot of states have sought Medicaid waivers, will be maintained over time. And then I think the community benefit dollar, there's been more and more push around having the IRS give guidance around housing and community development as an area of community benefit investment. They issued one clarification last year saying, yes, safe and stable housing is a community benefit, but there could be even further kind of push towards that as a good investment. But I actually think the real money is in the investment portfolios of these hospitals and healthcare systems, and they should become social impact investors with you, and you've got a great, you are the buyer, or sorry, you are the seller and they are the buyer. And so that is where I think we can create much more of a marketplace around these issues. Oh, I have so many questions and I'm feeling bad. All right, so let's talk about gentrification and structural racism. So I will first and foremost say that I do not think gentrification is a bad word. I think displacement is a bad word. And so gentrification to me is that the places that have been historically disinvested in over time, and this is well documented in redlining and other things, means that they are now getting investment. The problem is that almost always comes with displacement of the people that have traditionally lived there. And that, to me, is the key, is not that we should be trying to stop gentrification. I think we should try to stop displacement when gentrification comes. And that is hard. I struggle a bit. I think that I will say I've become kind of geeky about urban planning. I've been spending time at our Boston Planning and Redevelopment Authority, and it's an interesting conundrum. I think a lot of communities want a lot more affordable housing to be built in their neighborhoods as they gentrify, and then sometimes don't always want the density that comes with that thing. And I think this is where, as we think about kind of health impact assessments and scenario planning, I think we're going to have to make some trades in this, and we have to be really thoughtful about ways in which we can preserve land in gentrifying neighborhoods and be able to then find the right number of affordable units. And when I say affordable, affordable to extremely low-income people, affordable to the people who are more in the middle of the range, the 60 to 100% area median income, and then the more market. And that's where I think we haven't quite come up with the right formula yet. Like, is it 30% ELI, 30% workforce, 30% market rate? I don't love those terms, but it's basically trying to think through the roadmap of which we could try and move forward. I think that to me, the market, allowing the market to go unregulated perpetuates structural racism. And so I think we do need to regulate the market a bit and think through ways in which we can address the structural racism that has led to the places that are traditionally been disinvested in, and then be able to try and address that. And we have to be comfortable naming that as we kind of move forward. All right, so let's see. I'm trying to think about something that I haven't talked about already. All right. Oftentimes, resource allocation is filtered by the level of how deserving a population is. How do you make an economic argument for supporting housing for the undeserving, i.e. criminally involved in immigrants? I think that's a really great question. I think that in a lot of ways, I will often really try and question a lot of the framing that comes with both of those populations. So for instance, what I will say is we all have a goal, which is when people get out of prison, we don't want them to go back to prison, right? We all have that goal. And yet, we don't always align our actions to achieving that goal, right? We tell people who have been in prison they can't go home to live with their families, right? We make it harder for them to go back and live with their families. We make it harder for them to get a job so that they can stay out of prison, right? And so that as we kind of think about it, I think more and more we have to start with, what's our common goal? Our common goal is keeping people out of prison. And so if our common goal is that, then we need to align our actions that therefore are consistent with that. And this is, again, I like health impact assessments as a tool in the fact that they typically don't tell you not to do something. They typically talk to you about ways to mitigate the health detriments and to maximize the health benefits of any given policy. And so criminal justice reform, banning the box on certain things, banning the box is where people who apply for a job sometimes have to check a box to get a criminal background check. And so if you ban the box, you can actually open up yourselves to employ a whole subset of people that will be given a chance that will therefore decrease their likelihood of going back to prison. And so these are all, I think, conversations that I think have to start with a common set of goals and then be able to try and logically align the actions that therefore work with it. I don't want to act like it's easy, but I think that to an extent we are trying really hard to have a really kind of, I think, open conversation. To me, I think a lot of people want to talk about breaking the cycle of poverty. And I'm actually sad that home and housing does not come up as much in that conversation. People talk about education, people talk about sometimes criminal justice reform or other things, and I really want us to, David and I speak together other times, and when I talked about home as a vaccine, David, you said a really brilliant thing, which was kind of home is the first vaccine in a series of vaccines we need to break the cycle of poverty. It's not that education doesn't matter or jobs don't matter, but again, it may be the first one you start with as you build those things out. And I think we have to make that case a lot better. All right, I'm getting the 2-minute warning. I'm going to randomly pick out of the hat one question. Can we hold landlords accountable for health issues? Can we advocate for changes in policies that either may be more forgiving on rent, and then how do we deal with the threat of eviction? So I think this is a really good question. I highly recommend the book Evicted by Matt Desmond. How many people in the audience have read it? All right, some, good, awesome. It's I get no kickback for the plug of the book, but Matt is a good friend, and I think what I like is that he has really changed the conversation around the idea that people have thought of eviction as a result of poverty, when he's really said that actually, poverty is a cause of eviction, and he has really challenged us to say that no, that eviction is a cause of poverty, and that as we need to really think about our eviction laws, and we in Boston are looking at a just cause eviction law as a way to try and stabilize neighborhoods and to really look at the eviction maps, because what I think happens oftentimes is this idea of like, oh, people fall behind on rent and they end up evicted, but that is such a, as we think about kind of the ladder out of poverty, every time you're evicted, you drop down 3 rungs, right? It's kind of 1 step forward, 4 steps back. And as we think about ways in which to, there has been talk about in certain neighborhoods doing eviction-free zones as ways to both fight gentrification or slow gentrification down, or being able to think holistically about eviction, because the reality is that sometimes a family may be evicted over as little as $500, and that may be as much as it costs to house them in a homeless shelter for 4 days, right? So as you think about that, right, we are penny wise, pound foolish about a lot of these things. And so we instituted in Massachusetts a rental assistance for transitional families program to help stave off eviction for families that may just hit a bump in the road, not have the assets to do it, but within a small infusion of cash can get back on their feet and prevent an eviction. And so oftentimes I do think that looking at eviction policy, I think Mandy mentioned that you guys have some eviction maps, which I think is really, really the first step. Thinking through ways in which to do renter protections can be important. But I don't want to demonize landlords in this. I think landlords need to be part of the conversation, and I think that in a lot of ways there can be really creative programs that can be put in to help them do energy upgrades to their units or do other types of upgrades that then can say, okay, now that you've gotten this money, these low interest loans or other things in order to improve your housing, now you need to rent to a family to create stable homes for these families in these neighborhoods long term. And so I encourage dialogue with landlords, because I think that that is the only way that we're going to move forward. All right, I am so sorry to not get to these groups of questions. I am here for the rest of the day. I really look forward to it. I'm going to encourage you to come to our Track 3 panel, which is in this room later today, and just thank you so much for your attention.